Hi, my name is Scott Suko. I'm the Executive Director of the Liver Coalition here in San Diego, and we welcome you to our Liver Q&A webinar series. Today's topic is on viral hepatitis. We will be talking about hepatitis A, B, and C. We've got some great presenters, but before we get started, I wanted to introduce you to our sponsor for the webinar today, Dynavax, and to talk a little bit about Dynavax is Carl.
There we go. Thank you, Scott. Being that we're a little short on time, I just really wanted to thank you, Scott, for giving me the opportunity to sponsor this wonderful series of webinar Q&As. I wanted to thank Dr. Ramers, Dr. Gish. Here at Dynavax, we have come out with the very first 2-dose 1-month hepatitis B vaccine for adults, which both of our presenters have really good experience with. And I really just want to thank you, Scott, for putting this all together, and I'm going to throw it right back to you so we can get started.
Great, thank you, Carl. To talk a little bit about the Liver Coalition of San Diego, I wanted to introduce to you the president of our board of directors, Terry Cunningham, to share a little bit about how we started and what our commitment is to San Diego. Terry.
Hi, and welcome everyone to this wonderful series that we're presenting to you. I hope you find it extremely informative. The Liver Coalition of San Diego started a few months ago after the American Liver Foundation left San Diego, and we felt that we needed to have a presence here in San Diego for people with liver disease so that they could get their questions answered, get education, get some guidance, and be able to talk to experts. And that's exactly what we're doing today. We've got Dr. Gish and Dr. Christian Ramers, both of them incredible experts, not only in San Diego, but worldwide. And we appreciate their being here with us. They are on our board. If you have questions about the Liver Coalition of San Diego, please go to our website and you will find a lot of information there and a way to ask individual questions. So thank you again for being here. We are very glad to have your participation, and we look forward to hearing from you later on. Thank you.
Thank you, Terry. The way that we've got tonight's presentation focused is we're going to talk about hepatitis A and hepatitis B and then hepatitis C. And we're going to have Dr. Ramers talk about hepatitis A and C, and Dr. Gish talk about hepatitis B, and then we'll do some Q&A at the end. So throughout the presentations, if you've got questions, forward them using the chat box, the question box, and then I'll be organizing them and asking the doctors during the Q&A. Following the two presentations, we have a patient perspective by a board member who's going to share a little bit about her journey, and I'll let her introduce herself after the doctors speak. So with that, I'd like to start with Dr. Ramers on hepatitis A.
Thank you so much, Scott, and hello, everybody. It's a pleasure to be with you. We're going to try to make up some time, so I'm going to go quite fast through the slides, and I'm actually flying blind here, so I'm relying on my co-moderators to put up the slides here. The first should say the ABCs of hepatitis, A and C. If we could go to the next slide, that'll be my disclosures. And the next slide will be the learning objectives. I'm going to talk about hepatitis A, mainly on the transmission, the typical clinical course, and then talk about an outbreak that we had in San Diego that's now a multi-state outbreak. I'll pass it over to Dr. Gish for Hep B, and then finish up with hepatitis C and a quick run through the current state of Hep C care. Next slide. That's just moving into Hep A, and then the next slide should be Hep A background. So just to be clear about hepatitis A, this is a viral infectious disease of the liver, and actually in most cases it's mild and self-limited, but disease severity really increases with age, any underlying liver disease, people who are immunocompromised, or with other chronic diseases. It's not really known to cause a chronic infection, but interestingly, in the recent outbreak in San Diego, there was a clinical entity of relapsing hepatitis A, which had not really been previously described all that much, but was observed. And as you can see on the chart on the right that shows the clinical course with various parameters there, going through several weeks. This is not an overnight, very acute kind of thing over days, but over weeks, really 2 to 4 weeks, the symptoms come in. The transaminases or the ALT can get quite high in hepatitis A. And then eventually, by about 7 or 8 weeks in, we have what's called an IgG or an antibody, indicating really good immunity. And that immunity for hepatitis A is felt to last a lifetime and protect the individual from a future infection. Next slide. So here we have hepatitis A epidemiology. This is one of these stories that infectious disease doctors like myself love to tell because it shows the amazing success of vaccines. Hepatitis A is generally transmitted through food or through the oral fecal transmission route or person to person. As you saw on the previous slide, the incubation is anywhere from 2 weeks to close to a couple of months. And previously we thought this was something that was the risk was mainly in travel. But we've learned that there are many other ways of being transmitted amongst men who have sex with men, people who inject drugs, or just direct contact with an infected person. I show you on the chart on the right with the 3 different colored arrows, really the phased-in strategy of vaccination that's happened in this country, starting in 1996, where only high-risk groups were vaccinated, 1999, where children above age 2 in 11 selected states were vaccinated, and then 2006 is when universal childhood vaccination for Hep A occurred. And really, the major success story has been a 95% decline since this phased vaccine introduction approach. Unfortunately, the story doesn't end there. And if we go to the next slide, I dug into the National Hepatitis Progress Report, which goes through hepatitis A, B, and C and kind of gives us a grade of how we're doing. And Hep A on the top, unfortunately, you can see gets a big red X there because we're not doing too well. And that's shown on the next slide. The National Hepatitis Progress Report, what you see here on the bar graph on the left is a huge increase in hepatitis A cases throughout the country. They had been, around 2,000 or 3,000 cases per year, and they have shot up precipitously in 2017 and 2018 with what's called a multi-state outbreak. We've seen widespread person-to-person transmission of hepatitis A across the United States. The map on the bottom there, you can see, thankfully, those states that are gray are felt to have gotten over the outbreak, and the outbreak is considered ended. But all of these other states with the blue, light blue, and dark blue are seeing thousands of cases of hepatitis A, and we are way off from our goal. You can see on the dotted line on that original bar graph to get down below 4,000 cases. We're up over 25,000 cases in the last year that it was recorded in 2018. Next slide, please. So as I mentioned, Hep A used to be thought of as a foodborne disease, and actually the past 3 major outbreaks that were seen in the United States are listed here, where strawberries and pomegranates and scallops are really the source of all this hepatitis A, and this has really shifted to something that transmits directly from person to person, associated with people who are homeless and people who use drugs, whether they inject them or smoke them or share them. From 2017 onward, that's where it's been transmitted. The next slide, please. So in San Diego, when all was said and done, from about March 2017 to the beginning of 2018, there were over 700 cases of acute hepatitis A that were known. This resulted in over 20 deaths, mostly in people with underlying liver disease, such as cirrhosis or hepatitis B or C. It was a slightly less commonly seen genotype. And the risks that were really found from the case investigation were homelessness, use of illicit drugs, and poor sanitation, not having adequate toilets and bathrooms to use. You can say that this really looks like it started mostly in San Diego, but then quickly spread through other counties throughout California. You can see the case numbers there on the table. And then I've already shown you the national statistics where this is ongoing in the rest of the country. Next slide. So the silver lining here, I think, is that, vaccine really does work. And we had a massive vaccine campaign undertaken in San Diego. Over 100,000 people were vaccinated against hepatitis A, and that's really what brought this outbreak to a close. And then also, I would like to think that the county public health response really recognized that unsanitary living, where you just don't have a place to go to the bathroom, is really no way for people to live in the United States. And ironically, this became from a travel illness that was really only outside our borders to something that we had in our own cities. So, there's been some attention to this, trying to address these problems by housing people that are homeless and by at least allowing them to have a place to go to the bathroom and clean. their hands. And then on the top right there, you can see one of the most successful campaigns. A part of this to bring this outbreak to a close was bleaching the streets, literally by spraying our streets with bleach to kill the virus. Now, let me just finish by saying in the next slide, the vaccine, as I mentioned, is incredibly effective. There's several different versions of it. It's now part of the routine schedule for all children since 2006, but also recommended for adults who are traveling internationally, anybody with any form of chronic liver disease, anyone in a setting where there may be transmission, such as healthcare, group homes. And then during outbreaks, there's been an expansion of who needs a vaccine to really anybody who uses drugs or who is homeless, any men who have sex with men, or HIV positive person, or anybody with liver disease. And then they actually have in the guidelines, in quotes, anybody who requests vaccination. So if you go to ask for a Hep A vaccine, you should get one. On the next slide, I just list the different vaccines that we have there. They're mostly 2-shot vaccines that you get at 0 and 6 months or so, but really a lot of good protection even after the first dose. So I'll finish up with this last slide here, the take-home points for hepatitis A before passing it on to Dr. Gish. Really, transmission traditionally thought of as a foodborne illness, but there's been a shift in recent outbreaks to person-to-person transmission through the oral fecal route. The outbreak in San Diego, thankfully, is behind us due to a massive vaccination campaign, but really rages on in the rest of the United States. And prevention is possible with more widespread use of a very effective vaccine in at-risk populations. So thanks for your attention. I'll pass it over to Dr. Gish to move on to Hep B.
Lori, are you going to post my slides? This is Dr. Gish. Good evening, everybody.
Good evening.
I don't think we have your slides, Dr. Gish. If you want to share your screen, we can show them that way, or we can.
Okay. I'm ready to share. Just I emailed them like yesterday, but that's fine. Okay. How do I share my screen?
I just gave you access. Yeah, you should be able to do it now.
Nice. Okay.
Oh, great.
Move. Okay. So let's make sure you're seeing the right screen. Let's get all this organized because on Zoom sometimes it shifts the wrong screen. So I'm doing full screen. Let's do a switch. All right. Are you seeing a full screen now?
Yeah.
Yep.
Okay, great. So I'm going to move also quickly. Christian, that was a great intro. And of course, the big message at the end of tonight is everybody should know their ABCs. And I'm the B part. I'm the B team. And we're going to talk about hepatitis B. My disclosures are at robertgish.com. What's relevant potentially to a little bit of tonight's talk is the fact that I work with Gilead as a consultant on their speakers bureau. We're going to talk about epidemiology, virology in a short course, natural history, screening, facts, infections, and treatment options. Going to cover a lot in just 15 minutes or so, maybe 20. I'll try to move quickly. But before we get started on some of these important details, I really want to talk about testing for hepatitis B. So everybody that gets hepatitis B testing should get this triple panel. This is the panel that we look for chronic hepatitis B. Acute hepatitis B occurs, but it's quite rare relative to the number of people with chronic hepatitis B in the US, which is about 2.2 million. LabCorp, Quest, other labs, when people order hepatitis B testing, often go to an acute panel, and it misses key parts of the assessment. And I'll talk about what those are in just a moment. So this testing should be for chronic B or carrying B, carriage of hepatitis B. So the three tests are surface antigen. If that's positive, it indicates infection. And everybody who has hepatitis B infection should then get tested for hepatitis delta, D. D is for deadly. We're not going to talk much about that tonight, but everybody should know their ABCDs, if appropriate, for the D part. Core antibody indicates exposure, and that means to an incurable virus, persistence of infection long-term, even after S antigen is cleared. So the core antibody test is highly accurate with a 2 per 1,000 of being wrong or a false positive test. And it's extremely rare to have a false negative where it's negative that somebody has hepatitis B. I can't even give you a number. So core positive means exposure, means that there's some virus left in the liver even after surface antigen might be cleared. Anti-HBs indicates immunity only if core is negative. There's a lot of word out there on the street. This is one of those really wrong pieces of information about something called natural immunity. That is really not correct, can't be used today. If somebody is surface antibody positive and core antibody positive, the current correct terminology is immune control, meaning that they have a much lower risk of being reactivated. So people who are core antibody positive don't need vaccine, but they may need to be educated about the virus reactivating in certain settings where the immune system is suppressed, HIV disease, transplant, treating hepatitis C is another example. So I really want everybody to take home this message about the true news about core antibody and carry that forward. Now, if somebody is triple panel negative, they need to be vaccinated. And you heard already tonight about this 2-dose vaccine that has 2 great benefits. One is improved compliance and adherence, meaning people are going to finish a 2-dose much more likely than a 3-dose. Many people miss that 3rd dose. And even with 2 doses, we're getting a much better antibody response. And one thing we don't measure is another part of the immune system called the T cell system that also is stimulated by the vaccination process. Now, I'm not going to go into great detail on this slide because we don't have time tonight. I could spend 20 minutes just talking about what's here. But once a surface antigen test is positive, the rest of this evaluation needs to take place. And this is what we do as liver specialists, gastroenterologists, infectious disease specialists. There are primary care providers in our community who are expert at doing this as well, who we've trained and brought into the fold, because there aren't enough specialists or subspecialists to manage all the hepatitis out there. So this is really important. We can talk about this maybe at a future conference. Once another person, an individual's S antigen positive, I even do more workup, but I'm going to really emphasize something important on here, and that is alcohol. We really advocate people with hepatitis B shouldn't drink. There are statements about minimal, less, not much, but I'm afraid that when you tell people not much, you're not really sure how much not much is. And the same thing needs to be worked out for fatty liver, which is part of what's going on in our community today, which is the obesity epidemic and fatty liver epidemic. So everybody gets assessed for alcohol use, abuse, and fatty liver metabolic syndrome. This is a table I'm also not going to spend much time in, but you all could spend time when this is going to be on the web. It's a recording. You can hit the pause button and walk through this table and telling you what to do with the different profiles. So we call it profile 1 through 5, and then down below are the action items and interpretations that can take place. Very important to walk through this, print this out, carry it on your iPad, your PDA, your phone, and use this for interpretation. So back to numbers. 2 people are dying every moment worldwide from complications associated with hepatitis B. We think there's 292 million people infected in the world, with only 8% diagnosed and 1% getting treatment. So surface antigen positivity means linked to care, and treatment means lose weight. Don't drink alcohol. Test other people in the family. Vaccinate people who might be exposed. Of course, cirrhosis, transplant, liver cancer, and death are serious issues related to hepatitis B, and why we're advocating through the USPSTF, the CDC, our wonderful regulatory and advisory organizations that test every adult in the United States for hepatitis B. I hope that will be carried forward this next year. Hepatitis B has probably been around for over 40,000 years. They're finding this in mummies and different people because this B virus can survive for a long period, even intact or partially intact where it can be detected. It's a huge medical need. Look at the number of people that are infected and the downstream effects. So this is a global process for hepatitis B elimination. And Christian showed you a very nice table. Well, some places are reaching this, other places are not. The CDC came out with a recent initiative that's really going to step up activities in our country, provided they have the right level of funding. But the CDC has a fantastic attitude moving things forward this year into the future. This is S antigen prevalence. I'm basically going to say there's been a big drop in prevalence globally, especially in young individuals, because of birth dose vaccine and catch-up vaccine. So we're shifting from a lot of red countries to orange and orange to yellow. There is big gaps. We have this huge focus on HIV disease, but hepatitis C and D are killing a huge number of individuals, resulting in disability, resulting in stigma. These are infectious diseases. We really need to expand our focus on hepatitis B and C for a global effort and U.S. effort. This is information on hepatitis B. I said there were 2.2 million people, but at any given time, there's only about 100,000 people or 150,000 people receiving treatment. In some settings, it's even less. The Asia Pacific population, immigrant population in the U.S., 21,000 receiving treatment when this assessment was done. Now, this data is a little bit old, but I'm going to say it hasn't changed that much because we're not linking enough people to care. We're testing more, we're diagnosing more, but we still have a long way to go. Chronic hepatitis means liver inflammation, inactive disease, normal enzymes. Reactivation can take place. Cirrhosis is typically the pathway of inflammation. In cirrhosis, decompensated cirrhosis, liver cancer, transplant, and risk of dying. Each patient with hepatitis B needs to be staged and told where they are and what the future looks like. A little bit more on prevalence. Veterans, healthcare professionals, incarcerated, homeless, people who inject drugs, HIV infection, hepatitis C infection, and of course mothers and newborns born to hepatitis B infected mothers, and people with sexual risk behavior as well. We need to test all adults. We can't go through this risk screening all the time. That's what we've done in the past, risk-based screening, but that has failed in every domain. Once we have hepatitis B surface antigen positive, every patient needs to have a quantification of the virus. There's two ways to do that. You can quantify the DNA, that's the virus code, genetic code, or you can quantify the surface antigen. And I do both of these tests on my patients because the higher the viral load, the higher the risk of cirrhosis, cancer, transplant, and death, and the stronger the need for linkage to treatment, linkage to care, being on our wonderful 3 different options as first-line therapy for hepatitis B. Quantitative surface antigen, this is now coming to the forefront in the United States. It's been available globally for over 20 years. Sometimes the United States is the engine, sometimes we're the caboose. This is definitely a caboose issue. This surface antigen level, in my opinion, should be done on all patients. The level of that surface antigen links to many things. Risk for cancer, risk for transmission. Is the virus being cleared naturally? Is the virus being cleared on treatment? There's many uses of this very important tool, and my partners throughout the world have been using this for 2 decades. It's been difficult to get it here until Quest had this released about 3 years ago, and this year LabCorp has brought quantitative S antigen to the clinic. This is a serious disease, just comparing A, B, E, and C across different prevalence, and then talking about tuberculosis, HIV, and malaria. We need to make more noise. This should be at the forefront. Malaria and HIV and TB, of course, are important, but hepatitis is killing more people than these diseases combined. A little bit more, when we have a patient in clinic in front of us, we look at their liver enzymes, what's called the ALT. This is not a liver function test. This is a liver enzyme. It tells about inflammation, the activity of the immune system. We check the DNA level, we check the surface antigen level, then we fit the patient into one of these different phases. Not everybody fits in the 4 phases, but we try hard and then decide treatment, monitor, intervention, cancer surveillance. There's many different downstream outputs that we come to as we assess these different components. Rarely do we do liver biopsy now. We have many ways of non-invasive testing, but we take that non-invasive testing and tell the patient you have stage 0 or stage 1 or 2 or 3, which is bridging fibrosis. or stage 4, which is cirrhosis. It's very important to be clear to the patient about what stage they're in, and we try to project the trajectory, what path they're on. Are they progressing quickly or slowly? And sometimes we can get other information out of a biopsy or our non-invasive tests. How much fat is in liver is another key test that we can do. The number of infections are going up in the United States due to our opioid epidemic, increasing use of IV drugs, needle sharing. We need to change our harm reduction system in this country so everybody has access to clean needles, and then interventions for their use disorder. Geographic disparities. So what is North America? Well, we are the world, actually. We have a huge number of immigrants in this country. We make up about 70% of the surface antigen positive patients in this country. I have a number of my patients from East Africa, Sub-Saharan Africa, Central Asia, Asia subcontinent, such as India, and also Southeast Asia as well as China. Much more likely to be vertically transmitted, quiet disease for 2 decades, then becomes much more active. Adult-acquired hepatitis B, much better chance of natural cure, natural clearance of this virus. So we want prompt identification of all HBV-infected individuals. We want to implement important interventions, stop alcohol, lose weight, stage disease, know the level of virus, who to start antiviral therapy. We have entecavir, we have TDF, a tenofovir analog, we have TAF, another tenofovir analog. We want to decide who's at risk for liver cancer and start surveillance. This is an ultrasound. This is blood tests for liver cancer every 6 months. It's going to take somebody with special training to figure out who needs to start surveillance and who doesn't, and provide a callback system. Hepatitis A vaccination, you already heard from Dr. Ramers. This is very important to test and vaccinate. Candidates for testing, we at the Hepatitis B Foundation say everyone. We've gone through all these other risk issues that we've talked about before, but it's important to think about just testing everybody. Let's make it simple. Who do we treat? Well, it's really now about who not to treat. Viral level, DNA over 2,000 is a trigger. Liver enzymes over 20 to 25 in women, over 30 to 35 in men. Blood tests that indicate an increased risk for liver cancer. We have 3 blood tests for liver cancer that are FDA cleared that are very useful. Older individuals, active liver disease, family history of liver cancer, family history of cirrhosis, we're very likely to start treatment at a much earlier time point. Entecavir, just to show you a graph, people who are compliant with entecavir at 5 years, between 80 and 98% are viral undetectable. Similar with tenofovir, this is 8-year data with TDF. And remember, our new medication, TAF, is very similar to TDF, except safer, with lower risk of bone and kidney disease that can be seen with long-term TDF therapy. In those E antigen negative patients, this is a mutated type of virus, a later phase of disease, 99% have undetectable virus in their blood. Now, S antigen loss, which is called a functional cure, is a rare event, happening 1 to 5% over the first 5 years of treatment. Updated EASL recommendations, this is European data. It talks about when to use TAF over TDF, now called Vemlidy, referred to Viriad. Older age, risk for bone disease, ongoing kidney risk, ongoing kidney disease. The good news is on the right side is we rarely see resistance to these medications. Unfortunately, medicines like lamivudine, adefovir, telbivudine are gone. They're not part of our armamentarium in a normal setting. Finally, we need to immunize all of our newborns. Test all mothers. All individuals should be vaccinated. The mother is surface antigen positive. The baby should be getting immune globulin and vaccination, hopefully with just in a few hours of birth. And we can break this transition, this transmission problem. Vaccine is great. We have this 2-dose option for adults. We have burst dose for children, all children. more intensive management for the baby at birth if the mother is surface antigen positive. And the mother might even be treated with the medicine during the 3rd trimester, the last 3 months of her pregnancy. So some countries are getting towards the elimination goal, other countries are not. Look at this, by 2030, getting to a target of less than 1%, we're seeing lots of green on here. Places in the Southeast Asia, Asia Pacific, and Africa really need help to catch up with us. So finally, test all adults for hepatitis B with a triple panel core antibody test. Let's not misinterpret this. This indicates persistent virus in the liver, even if surface antigen is negative. Triple panel negative, vaccinate, consider our wonderful 2-dose regimen that we have. Consider staging, consider linkage to care, treat until S antigen loss, now called functional cure. It's not a real cure, but it does have a much better prognosis when S antigen is gone, as well as DNA undetectable. Thank you very much for having me. I know we moved quickly. This is going to be recorded. The slides are going to be shared on my website as well as our wonderful coalition website. And I look forward to our next presentation, ABC.
Thank you, Dr. Gish. And yeah, at this time, what we're going to do is keep moving forward. And a couple of folks have forwarded questions, and we will get those answered, but we'll do them at the end. So we'll have Dr. Ramers at this point move forward with hepatitis C, and Lori's going to put the slides up and walk us through it.
Great, excellent talk, Dr. Gish. I'm happy that you had to do B because it is the most complicated of the 3. But progressing on to hepatitis C, Lori, if you could just tell me when slide 15 is up. That's the epidemiology, screening, transmission, treatment, cure.
Yep, should be up.
Okay. Great. So you can go to the next slide, the status of Hep C in the world. So moving to hepatitis C, the prevalence of Hep C is really not quite as high as hepatitis B. As you heard, almost 300 million people with hepatitis B. We're at 71 million in the world, we think, that have hepatitis C. But what's concerning is there's almost 2 million new infections per year, and this is actually happening mostly through unsafe healthcare injections and injection drug use. Next slide. The risk factors for transmission of hepatitis C are all that's listed here, which mostly have to do with blood-based transmission. Now, you'll see that there are a couple of panels here that talk about sexual transmission, and for a long time we didn't really think sexual transmission was very common. There are many studies with stable heterosexual couples that show extremely rare transmission of hepatitis C, to the point where researchers wondered whether it was even not from sexual activity itself, but maybe from sharing a razor or a toothbrush that might have had a microscopic amount of blood on it. But we do now know that in male to male sexual activity, this is not a rare occurrence. In fact, in my HIV clinic, we have many men who have sex with men, and we do see every couple of weeks, actually, an acute hepatitis C case that is probably through sexual transmission. But far and above, the most common way to get hepatitis C is through sharing of blood from an infected person. That comes through a blood product that has not been screened, from sharing needles through injection drug use. And what's not listed here are other ways to share blood, and that would include things like tattoos in an unclean environment, such as in prison, or getting injections in medical settings where they are not using sterile equipment. Next slide. So it's pretty easy when you get down to the details of what injection drug use involves, why Hep C transmission is so common. So this is not generally a clean procedure. It's things that are done out in alleyways and in people's homes and people who are really in the middle of the throes of their addiction. And you see all the equipment here: the water that's used, the filters, the gauze, the needles. Any of these things, if there's Hep C contamination, can lead to transmission of hepatitis C. And on the next slide, what's really impressive about Hep C is how robust it is. HIV as a virus really is pretty wimpy. You expose it to air and it just cannot survive. But these experiments just blow my mind every time I look at them. The duration that hepatitis C can survive in a closed syringe is up to 64 days. And even just in a water container up to 21 days, even on a surface up to 21 days. So just a drop of contaminated blood really can stay infectious for probably 3 to 6 weeks in some of these cases. It's no wonder that there's a lot of hepatitis C, and it's no wonder that some people don't even really remember what their exposure might have been. Next slide. So what I show here on the left panel of this slide is really the story that we heard about Hep C epidemiology for a long time, and that is that this is primarily a disease of baby boomers, and that there's just a real even distribution, mostly 40 to 60-year-old individuals, mostly men, and many of them were infected long ago, well before hepatitis C was even discovered. And I will pause here and just note that the Nobel Prize was just awarded to the 3 scientists that actually discovered the hepatitis C virus in 1989. Keep in mind that before 1989, our own blood supply in the United States was not necessarily clean of hepatitis C. So there were years where there were thousands of cases of hepatitis C that were given via blood transfusions. Doctors' offices also did not necessarily adhere to universal precautions in the use of sterile instruments. And so there probably was some ongoing, what we call nosocomial transmission as well. So we've been left with this very large cohort of individuals in the baby boomer age group that gave us this nice sort of unimodal curve. And if you advance to the next slide, the panel should open up on the right-hand side. And what that shows us now is that we're really in the middle of a bimodal distribution. This is just going from 2002 to 2009, the incidence of hepatitis C by age in Massachusetts. And you can see this single peak has now turned into 2 peaks, where we have the older individuals between age 40 and 60, part of the baby boomer generation, still with plenty of infection there, but really a lot more young people getting infected. And that is because of younger people and injection drug use primarily. On the next slide, I just couldn't resist showing a little bit of data from San Diego. At Family Health Centers, we've been doing community-based testing for a while. This was actually back in 2013 or so. And of the first 300 people that we tested, you can see a nice bimodal distribution, plenty that were in their 40s and 50s, but then a lot all the way down to age 20 who were positive as well. Next slide. So just very briefly, the testing for hepatitis C, not nearly as complicated as hepatitis B like you saw earlier. Basically, 2 things you have to remember. The antibody test, sometimes called anti-HCV or HCV antibody, this is just a marker of exposure. It indicates past or active infection, and it really does not confer immunity to the virus. In order to confirm active infection, a second step must be done, which is called a viral load or an HCV RNA test. And if this is positive, this indicates active infection. We've tried to get away from this being 2 separate tests. Most places that you send a test, you can order a single tube of blood, and they'll actually run both tests in a reflex manner, so you don't lose people from the first test to the second test. Next slide, please. So I think this is going to be a build slide here. The screening recommendations for hepatitis C have undergone really a dramatic change just in the last year. So the first panel here, you can see the U.S. Preventive Services Task Force. This is an independent panel that advises doctors' offices and insurance companies on which tests should be part of general prevention in medical care in the United States. And they had a public comment period and eventually gave universal testing of all adults from age 18 to 79 a B grade, meaning that the preponderance of the evidence suggested this is something we should do. And anything above a B or above, is really considered part of good primary care. If we advance the slide one more time, we'll get to the CDC recommendation, which also fell in line this year, that universal screening should be undertaken, that a little bit more specificity to their recommendation, that anybody age 18 and above, except in settings where prevalence is very, very low, less than 0.1%. I happen to know the director of CDC hepatitis who came up with this, and she said, conveniently, every single state in the U.S. has a prevalence above 0.1%. So that pretty much means everywhere. And then because of some of the massive outbreaks happening in the Midwest and in the Appalachian region, related to the injection drug use epidemic, screening all pregnant women during each pregnancy is also recommended. And if we advance one more time, the final part of this slide, just in terms of higher risk groups, the AASLD and the IDSA guidelines actually say screening should occur not just once, but actually every single year in people who inject drugs and among HIV-infected men who have sex with men because of the increased risk of transmission in these groups. The next slide, I just want to have a single statement up here about treatment, which is also from the AASLD and IDSA, which says clinicians should treat HCV-infected patients with antiviral therapy with the goal of achieving an SVR, that's called a sustained virologic response, or the same thing as cure, preferably early in the course of their chronic Hep C infection before the development of severe liver disease and other complications. This sounds like such a simple concept that we want to identify people, treat them, and cure them before all the problems happen with their liver. But over the last 5 years, we've had a whole lot of fights in terms of who deserves to get Hep C treatment and who has access to the treatments. But thankfully, at least in California, we have really very good access to treatments. Anybody that has hepatitis C really can access treatment and cure. On the next slide, I'll run through the natural history of Hep C. It should be noted that not everybody exposed to Hep C gets a chronic infection. So you can see the numbers here, 15 to 25% will actually have spontaneous resolution. Some studies have even shown this higher than that, about a 30 to 40% rate. That means that people will have an antibody that's positive, but they won't have that positive viral load. And that's why that second test is really important. Most will go on to persistence in what we call chronic infection. And then over a period of about 20 to 30 years, and if you advance one more time, I think you'll see a big arrow showing us the timeline. Over about 20 to 30 years, about 20 to 30%, just a general rule of thumb, will develop cirrhosis. And then from there, that's when the bad stuff starts happening. ESLD stands for end-stage liver disease or liver failure, and HCC is hepatocellular carcinoma, and you can see these constant rates per year. That's really not a good place to be because you're really at risk of having bad things happen. If you advance one more time, I think you'll see the acceleration of this whole timeline if you have concomitant Hep B infection or alcohol or HIV disease, and I would probably add, it's not on the slide, but fatty liver disease probably deserves to be on there as well. Next slide, I think we'll see the stages of the liver. In terms of the stages of fibrosis, we use a system commonly called METAVIR. Stage 0, as it looks, is a normal, healthy-looking piece of liver tissue. Stage 4 is really with a lot of fibrosis and scarring, a lot of collagen deposition in the liver, and you can see there's really not much healthy liver tissue left. And then stages 1, 2, and 3 are kind of in between, intermediate between those stages. Go to the next slide. This is what actual liver tissue looks like in biopsies. Like Dr. Gish mentioned, we don't tend to use biopsies that much anymore. But as you can see, stage 4 over on the far right there in the METAVIR scheme is really full of that bluish purple color, which is really not viable liver tissue. And you can see how it's going to have a hard time doing its job. In the next slide, I just want to show two quick pictures of the ways that we actually determine liver stiffness these days, or liver fibrosis. The first is called a fibroscan, or transient elastography. Very quick and easy procedure that we do in the office. It just takes about 5 to 10 minutes. And really, without any trouble, non-invasively, we can determine whether you're in that F0, 1, 2, 3, or 4 stage. On the next slide, you see a slightly different technique, which is called shear wave elastography. This particular example is a patient with F4 fibrosis. A really easy ultrasound-based technology where we just stick this on the side of your torso between your ribs and get an idea of where you are. Next slide, we can move to talking about treatment. Now, I show you this not to scare you, but this is what Hep C treatment used to look like. When I started treating Hep C, it involved a shot once a week, somewhere from 10 to 18 tablets a day, divided into twice daily and 3 times daily dosing, extremely complicated. Sometimes this went on for a year with a whole list of side effects. And if you go advance the slide one more time, we are definitely not in that era anymore at all. On the next slide, you can see how successful the therapeutics have been. Nearly everyone with HCV can now be treated successfully. And thankfully, we've seen this upward march in the SVR percent. Remember, that term means cure. Going way back to the early 90s when Hep C had just been described, interferon was used for these 6-month courses with only about a 6% cure rate. I'm glad that I wasn't practicing back then because that would have been very tough to get through all of those side effects and just a 6% chance of getting cured. Thankfully, we're up to these all oral therapies now where the cure rates are above 95%, and it's just very rare that somebody doesn't get treated and cured. On the next slide, I'm going to mix this alphabet jumble of all these different, and you can actually advance until the whole screen is full. I think the last one that comes on there is Tebrentisfir at the bottom. There was a period of intense development of these drugs to the point where we had to memorize a new drug name. It seemed like every month or so, falling into 3 different classes. And thankfully, things have gotten really a lot more simple. So if we advance to the next slide, we are now at the point where we have a very simple algorithm for hepatitis C. There's only a couple things that people need to do in order to get their Hep C treated and cured. The first is confirmation of an active infection. That means getting that viral load test. The second is a pre-treatment assessment where we generally do non-invasive fibrosis staging and a couple of lab tests. And then we just choose one of two regimens. We're really down to only two regimens these days that are predominantly used. And the reason we're down to two is because they treat all different genotypes and they're basically equivalent in terms of their effectiveness, 95% cures. The first one is called Maviret that we prescribe for 8 weeks, and the second Epclusa for 12 weeks. Most people do not even require on-treatment monitoring. This is just a big departure from the interferon days when we had to bring people in almost weekly for labs. For most people, no on-treatment monitoring is required. Of course, if there are complicating factors like hepatitis B co-infection or cirrhosis or severe liver damage or HIV co-infection, then it is advisable to come in and have blood tests during treatment. But as is outlined on the right-hand side, this is the AASLD-IDSA simplified treatment algorithm. If you don't have cirrhosis and you haven't been treated before and you don't have hepatitis B, kidney failure, or HIV, no treatment monitoring is really required. Now, it is important to come in for a post-treatment assessment. That's the thing we call SVR12. That's a blood test taken 12 weeks after one finishes their Hep C treatment course. And if we want to see that to be undetectable, and that tells us that somebody has been legitimately cured. If you go to the next slide, you can see sort of what this looks like in practice is somebody's viral load really within the first 4 weeks usually of treatment goes down to undetectable. They're not cured at that point because there's probably some virus left in the liver all the way through to the end of treatment completion. And then the standard practice, again, is to wait 12 weeks after that treatment completion and check another viral load. Again, if that's undetectable, we consider that a cure. Now, a lot of patients ask, well, does that mean it's just dormant? Does that mean I have to still worry about this? A cure is a cure. This is now a virus that is no longer in your body once you achieve that SVR. It's important to know that an antibody test will probably stay positive, but an antibody test is just a marker from your immune system saying that you've been exposed. It doesn't mean that there's any Hep C virus left over. Now, one last thing that I tell all my patients, once they achieve that SVR12 and we celebrate, we actually ring a cure bell in our clinic, and it's a very happy moment. For many people, hepatitis C is a burden that they've been carrying for years, psychologically, maybe from prior drug abuse or from a tattoo they didn't want or from gang activity or that type of thing. It's a great thing to get this and cross it off their list. But people need to remember that they are still vulnerable of getting reinfected if they're re-exposed again. On the next slide, and we can actually advance the animation so we can see both sets of livers there. Treating and curing hepatitis C is one of the biggest medical interventions we can possibly do. Most of what we do in medicine does not give us these incredible reductions in morbidity and mortality. Curing Hep C is associated with 70% reduction, roughly, in liver cancer, 50% reduction in mortality, and about a 90% reduction in liver failure. And in some cases, we do believe that livers that are scarred, as the one on the left is shown there, may in fact actually heal themselves and become livers that look much better and can carry somebody well through into their older years. So not much that we do in medicine gives us this incredible benefit as treating and curing hepatitis C. So I'm going to finish on the next slide with just a couple of snapshots about elimination, and then we can finish up. On the next slide, I just wanted to show a snapshot of the global hepatitis report that the World Health Organization put out in 2017. And with this report, they essentially threw down the gauntlet and said, look, we have the tools available. We have non-invasive liver stiffness measurement. We have direct-acting antiviral therapies that are 95% effective. We should be able to eliminate hepatitis B and C, actually. This was a comprehensive B and C report. On the next slide, you can see the strategy of what needs to be done to eliminate both Hep B and Hep C by 2030. Gets a little complicated with some of these things. Dr. Gish mentioned vaccination for Hep B and prevention of mother-to-child transmission being crucial to get to elimination of hepatitis B. But the two red circles on this table show really with Hep C what we need to do. We need to diagnose 90% of people with hepatitis C, and we need to treat 80% of those that are diagnosed. We definitely have a long way to go to do this because I can tell you there's many, many people that don't know of their Hep C diagnosis, and even many people with Hep C that have not yet achieved cure or been referred to somewhere where they can get treated. On the next slide, you can see that we actually do have a national strategy in the United States. I think Dr. Gish actually contributed to this strategy and commented publicly. This was put out by the National Academy of Sciences, Engineering, and Medicine, which is a wonderful group. They've been instrumental in a lot of our COVID response so far. Independent, non-governmental group really does their best to eliminate any bias or political influence and just sticks to the best science about how to do things right. They published this report in 2017, really laying a roadmap of how we can eliminate hepatitis B and hepatitis C in our country. And the highlights of their recommendations is on the next slide, the U.S. National Strategy, key recommendations. We kind of know what to do here. We need to identify best practices for screening, and thankfully we now have recommendations to screen all adults. We need to expand access to syringe exchange and opioid agonist therapy. This is something a lot of people are not comfortable talking about. Addiction is a very difficult topic for many people to talk about with their providers. But we now have ways to prevent infection being transmitted by allowing clean syringe exchange access and treating people's underlying addiction problems with opioid agonist therapy and other addiction treatments. This used to be kind of fringe and very progressive, but it's really completely mainstream now. In fact, part of the national HIV elimination strategy, part of our Secretary of Health and Human Services strategy under the Trump administration, and part of CDC's recommendations is to expand all of these harm reduction interventions. The next bullet is to remove treatment restrictions. We've gotten there in California, thankfully. The next one is to build primary care capacity for Hep C treatment with the support from specialists, and the ASLD and IDSA have been instrumental in this. They suggest a national system of care and support for patients to address all of their social issues along with the hepatitis C and liver disease. We have to target prisons because prisons are places of high hepatitis C prevalence and high transmission. And then finally, a pie in the sky idea is that the government should maybe purchase their own direct-acting antiviral drugs and use them at a reduced cost. Many other countries do this throughout the world. In fact, Rwanda is on the course to eliminate hepatitis C next year in their country, but not quite in the United States. It doesn't quite work with our system. So how are we doing? On the next slide, I just want to show you progress on incidence of hepatitis C from this same National Progress Report. On the top left is the goal on that dotted line showing that we want to reduce incidence of new infections by 20% from 2018 to 2023. You can see the goal is to go down to 35,000. Unfortunately, we're going up the wrong direction. This is, of course, because of the opioid crisis in our country. Lots of new infections out there that are occurring. Over on the right-hand side, specifically looking at people who inject drugs, the goal is to reduce by 25%. And again, we are headed in the wrong direction. So we get a big red X for both of those. I will end with some good news, though. On the next slide, the progress on mortality is actually in the right direction. So as of 2018, you can see a declining mortality in those that have hepatitis C. And that's probably because we're identifying people with advanced liver disease, treating them and curing their hepatitis C, and literally saving their lives. So we get a nice green check mark for that, making progress on mortality. We just need to do more in terms of prevention. As Dr. Gish mentioned, there are very good people at the CDC making this a priority. The findings of the National Progress Report really show that we need to detect and stop transmission of Hep C and do a better job of that. We need to improve testing and linkage to care for persons with chronic Hep C, many of whom don't always access the healthcare system in traditional ways. And they have some suggestions that progress can be achieved by implementing community-level programs for people who inject drugs. That includes syringe service programs, medication-assisted treatment, and then, of course, vaccination. We need to increase the proportion who have chronic Hep C who are referred to care and who receive treatment. And then finally, we need to do something to decrease drug costs. And there's already been quite a bit that's achieved since these drugs were first available. And I think there's still more to be done. So I'm going to give my closing thoughts here, combining hepatitis A and C. Thankfully, in San Diego, we are behind. The hepatitis A outbreak is behind us, but again, rages on in the rest of the United States. The thing about Hep A is vaccinate, vaccinate, vaccinate. Remember that we have a fully comprehensive childhood vaccine series, but it wasn't really initiated until the 90s, and so you have a pretty vulnerable adult population that is not protected against hepatitis A. And finally, in terms of hepatitis C, this is a curable and preventable disease, and efforts focusing on improving policy, expanding treatment access, have placed elimination within reach. I would say we know what to do. We just now need the political will to do it. So thank you so much for your attention. I'm going to pass it back over to our moderators.
Great. Thank you, Dr. Ramers. I do have just a couple questions, and then we'll move on to our patient perspective. The first, Dr. Ramers, for you, could you clarify, you mentioned 2 treatments, and the question was to treat hepatitis C. What is the mechanism that those treatments use?
So they're actually, the 2 treatments are both combination treatments, and they each have different drugs inside of them. So using just a single treatment for hepatitis C is not going to do it. Like we do with HIV, we like to attack the virus in 2 different ways. And each of these treatments have a mixture. In the case of the Epclusa, that's a combination of sofosbuvir and valpatisvir. That inhibits the polymerase and an enzyme called the NS5A enzyme in the hepatitis C, which basically stops the virus from being able to replicate itself. The other combination is called Maviret, that is glucapavir and pibrentasvir, again from 2 different classes. One of those is a protease inhibitor, which stops the protease, and the other is an NS5A inhibitor. And the effect of that is really to stop the virus from being able to make copies of itself. So the drugs come in, they stop the replication of the virus, and then the immune system is actually then able to clear it out completely, and that's what results in a cure.
Okay, great. And then Dr. Gish, if you're still with us, and then if Dr. Ramers, you add on to it as well. What should patients with hepatitis A, B, or C be thinking as it relates to COVID and then the upcoming vaccine that's being talked about?
So from a hepatitis A perspective, there's minimal impact, and just keep promoting and advising hepatitis A vaccine for those who are susceptible. It's an acute disease. It's going to be rare in this current time period because of, I think, decreased social interactions and the incredible efforts in the community of vaccination that's taken place with our San Diego Public Health Department and Christian's work. Hepatitis B and C are chronic diseases, and everybody with B and C should know how good or how bad their liver disease is. People with more serious liver disease can suffer more complications during a COVID infection. So it's important to be identifying the disease, the stage of disease, and letting healthcare providers know that they have an infection and their liver health. And of course, people need to take all those special precautions of the personal protective equipment, social distancing, hand washing, avoiding enclosed places, especially those with poor ventilation, close contact with individuals who are at risk or have infection.
Yep, I would agree with that completely. The standard recommendations still apply, and I think what the question implies is that people might be worried. Do I have an increased risk if I have a chronic liver disease? I've seen some studies that say yes, liver disease does come out as a risk factor for a more severe outcome, but not all of them do. Remember that COVID is primarily a respiratory virus, and so people with respiratory or cardiac issues are going to be the highest risk. But it also is a systemic disease virus, and so people that have fatty liver or that have diabetes also have shown more severe courses of COVID. So everything we've said in terms of the non-pharmaceutical interventions, such as distancing and masking, masking, initially in the outbreak of COVID, we weren't even sure how well they worked. And every single piece of evidence in the last 6 months, I would say, has just continued to show the benefits of wearing a mask. So I would say do all the same things. And then, yes, there's probably a little bit of extra concern that we have in those with chronic liver disease.
Thank you both for being with us tonight and sharing that information. And we'll wrap up our Q&A section and then move on to the next part of the webinar, which is our patient perspective. Before I do that, I do want to remind folks that there are some of those attending that are participating for CE through Mark's training, and Peggy Beers, our program manager, will be sending out a follow-up email with an evaluation that you'll fill out with a questionnaire, and then that will prompt the issue of your CE for attending tonight's webinar through Mark's training. At this point, I'd like to introduce Lori. Lori Pluchek is on the board of directors for the Liver Coalition of San Diego, an amazing leader locally, and as well as been participating, there you are, Lori, on a number of initiatives. So just so glad that you've made yourself available and I'll just leave you to talk about some thoughts that you have after today's webinar and share a little bit about your journey.
Hi, everyone. My name is Lori, and I met Scott, let's see, about 4.5 years ago. I became a member of the board of directors of what is now the Liver Coalition of San Diego. And one of my main interests and roles on the board is patient advocacy. I am a patient with liver disease. My history, 6.5 years ago, I was diagnosed with HCC, or primary liver cancer. This came out of the blue. I am a non-drinking, very thin, athletic person with I had no symptoms. Luckily, it was discovered when they were searching for something else, doing a scan, and I was able to catch it fairly early. At that time, they found out that I have hepatitis B. I'd had a blood transfusion at 2 days old, back before we screened our blood, and I most likely contracted hepatitis B at that time. And I have, at some point in my life, sero-cleared the virus. I'm one of the lucky ones. I don't have any active virus, but I am, as Dr. Gish said, I am surface antibody positive and core antibody positive. So I do all the things that I advocate for now. I advocate for screening, regular testing, all the scans that I have every 6 months for the rest of my life. And I am here to speak to you today to say that you can live with this. You can do this with the amazing medical help we have and the great progress and strides being made. And I am a 6.5-year liver cancer survivor, and I live with hepatitis B. So I feel like to give back. I do a lot of advocacy. I've gone to Washington, D.C. 3 years to advocate on Capitol Hill for increased spending for research for liver disease. And I talk to other patients. It's a very scary diagnosis. It's frightening to find out that you have liver cancer or hepatitis, but it's helpful to know there's others out there that you can talk to. And I think the work that's being done here in San Diego and around the world is so important. As a patient, it gives me great comfort to know that there are people working on our behalf. So thank you.
Great. Thank you so much, Lori. And thank you all for being with us tonight and sharing your evening with us, and for our presenters and our sponsor with Dynavax. As a community, we're coming together, and Dr. Hassanin said, from the community for the community. And that's our motto. So thank you very much and have a great evening.